Welcome back to the deep dive. Today we're getting into a specific set of revision notes you've shared, zeroing in on a pretty common injury.
That's right. We're looking at radial head fractures today, taking these notes you send over and really breaking them down.
Yeah, the plan is to unpack everything, pull out those absolutely crucial bits for revision, the high yield stuff, and help make those connections so it sticks.
Exactly. Less like just reading notes, more like finding the story behind the fracture, what triggers it, potential pitfalls.
And hopefully making it easier to remember. Okay, let's dive in. Starting right at the top. What exactly is a radial head fracture?
Okay, so at its core, it's a break in the radial head. That's the bony bit right at the top of the radius bone.
The radius being one of the forearm bones?
Yeah, the one on the thumb side. And the radial head is right there, forming part of the elbow joint.
Gotcha. And the notes mention these aren't all identical injuries. There's some variation.
Oh, definitely. That's a key point in these notes. The severity really varies. You can have just a tiny crack, barely out of place, what we'd call non-displaced.
Right.
Or it could be much worse, severely displaced, broken into multiple pieces, fragmented.
Wow. Okay.
So yeah, when you're revising, think spectrum, not just one type of break. That variation is crucial because it changes how you manage it.
That makes total sense. The type of break affects the treatment. So, how does this actually happen most often? What's the usual story?
The classic mechanism, the one these notes really highlight, is a fall onto an outstretched hand, FOOSH, as it's often abbreviated.
FOOSH, fall and outstretched hand.
Right. But there's a detail here. Often the forearm is pronated.
Pronated, palm facing down.
Exactly.
Yeah.
That specific position.
Why is that position so important, that specific twist?
Well, when you fall like that, the force shoots up the arm, and the radial head basically gets jammed against part of the humerus, the upper arm bone called the capitellum.
Ah, okay. So it's a compression injury.
Yeah, compression, often with that twist from the pronation, that's what causes the fracture. The notes also mention other causes, like a direct hit to the elbow.
Like in sports or an accident.
Right. But that FOOSH with pronation, that's the really high-yield mechanism to lock in.
Okay, FOOSH with pronation. Got it. So knowing that's how it happens, who's more likely to, have that kind of fall? Who's most at risk?
The notes point to a couple of main areas. First one is activities.
High-risk activities.
Yep. Things where falls or trauma are more likely skateboarding, cycling, contact sports. You can see the direct link to that fall mechanism.
Makes sense. What's the other main risk factor group?
The other factor is more about bone strength itself. So older age can be a risk factor, and conditions like osteoporosis that weaken the bones.
Weaker bones mean they break more easily, obviously.
Right. Less force needed to cause a fracture.
Okay, so it's interesting, though. The notes mention osteoporosis as a risk, but then later say it's most common in young adults. How do those fit together for revision?
That's a really good point to connect. It seems a bit contradictory at first, doesn't it?
Yeah, a little.
But the reason we see it so often in young adults, even though their bones are generally strong, is because they are the ones more likely doing those high-risk, high-energy activities.
Ah, so it's exposure to the mechanism.
Exactly. While weaker bones make anyone more susceptible if they fall that way, the sheer frequency of those types of falls in active young adults makes them a very common patient group.
So risk is about both the chance of the fall and the bone's resilience, activity and age bone strength. Got it.
That's a good way to summarize it. Activity and age bone strength.
Okay, let's go a bit deeper. Pathophysiology. What's actually going wrong inside the elbow beyond just the bone being broken?
Well, the radial head isn't just a lump of bone. It's vital for elbow stability and movement, especially forearm rotation, turning your palm up and down.
Right, supination and pronation.
Exactly. So when it fractures, that disrupts the joint's normal mechanics. And that disruption is what causes the immediate things you see, like the pain, the swelling, the difficulty moving.
And you mentioned displaced fragments earlier. What about those?
Yeah, that's crucial. If the fracture pieces shift out of place, if it's displaced, those fragments can actually start impinging on other things in the joint.
Impinging, like getting in the way.
Yeah, catching, rubbing against, pressing on the joint lining, maybe ligaments, cartilage. That obviously makes the pain worse and limits movement even more.
And probably leads to longer-term issues, too.
Definitely. A big factor in potential complications down the road.
Okay. So someone comes in with elbow pain after a fall. How do you differentiate? How do you know it's this fracture and not something else? What's on the differential diagnosis list?
Good question. You definitely need to consider other possibilities that can look similar. The notes list a few key ones.
Such as?
Things like an actual elbow dislocation where the joint comes out of place, Other fractures around the elbow, maybe in the forearm bones like the ulna.
Mm.
Ligament injuries are also on the list. Sprains or tears, and even just significant joint inflammation from the trauma itself.
So for revising, it's like a mental checklist. Is it this bone break? Or did the joint slip? Is it another bone nearby? Is it soft tissue damage? Or just inflammation?
Precisely. That's the thinking process. The notes give the list, which is the first step, knowing what else it could be.
Right. Moving to the bigger picture, then epidemiology. How common is this specifically in the UK context mentioned in the notes?
The notes state they're quite frequent elbow fractures in the UK.
Okay, so pretty common.
Yeah, and particularly common among adults, with a specific mention that they're most often seen in young adults.
Which again circles back to those risk factors and activities we talked about.
Exactly. It all links together. It's a common injury pattern for that demographic.
So let's talk presentation. If someone has this fracture, what are they going to notice? What signs and symptoms do you look for clinically?
The classic picture is pain, some tenderness when you touch the area, and swelling. Usually that's focused on the outer side of the elbow.
The lateral side.
Yep, the lateral elbow.
And what about movement? How's that affected?
Typically, there's a limited range of motion.
Hmm.
Trying to fully straighten the arm extension can be difficult, but a really key thing the notes highlight is pain and limitation during forearm rotation.
Turning the palm up and down again?
Exactly. Sharp pain during that specific movement is a very telling sign.
That makes sense, given what you said about the radial head's job in rotation. What if it's a more severe fracture? Does it look different?
It can, yes. In more severe displaced cases, the notes say you might actually see some visible deformity around the elbow. Bruising is also common.
Wow.
And importantly, the elbow might feel unstable when you examine it.
Right. So, quick summary for revision. Pain, swelling, limited movement, especially rotation. And if it's bad, deformity, bruising, instability.
That's a great summary. Nail those points.
Okay, so you suspect it based on how it looks and feels. How do you confirm it? What investigations are typically done?
The first step, the standard investigation, is x-rays, elbow x-rays.
And those usually show the fracture.
Usually, yes. They're pretty good at picking up the fracture and giving an idea whether it's displaced and how badly.
What if the x-ray isn't totally clear, or you think it might be more complicated than it looks?
That's when a CT scan comes in handy.
Computed tomography.
Right. CT gives much more detailed cross-sectional images. It's really useful for complex fractures, getting a precise look at the displacement, or checking for other associated injuries like cartilage damage that don't show up well on x-ray.
So imaging confirms it, tells you how bad it is, and that helps decide the treatment.
Exactly. The imaging is vital for classifying the fracture and guiding the management plan.
Okay, let's talk management then. Once it's diagnosed and you know the severity, what's the plan? How do you treat these?
Well, as we touched on, the treatment really depends on the fracture type. Specifically, how displaced it is, how complex it is, and if other structures around the elbow are involved.
So what about those simpler ones, the non-displaced or minimally displaced fractures?
For those, the notes describe conservative management.
Meaning no surgery.
Right. Typically, it involves immobilizing the arm for a short period, often just in a sling, maybe a splint, just to let things settle and start healing.
Okay.
But then pretty quickly, the focus shifts to physical therapy, getting that movement back.
Why so quickly on the physio?
To prevent stiffness. The elbow gets stiff really easily, so if the bone pieces are in a good position, you want to support them, but get the junk moving early on.
Right, makes sense. And what about the more complicated ones, the displaced or complex fractures?
Those usually need surgery. The notes mention a couple of main surgical options.
Okay.
One common one is ORIF, open reduction and internal fixation.
Sounds intense. What does that involve?
It means the surgeon makes an incision, that's the open part. They physically put the bone fragments back into their proper alignment, the reduction, and then they use hardware, like small plates and screws, to hold everything in place while it heals. That's the internal fixation.
Okay, ORF. Putting the pieces back and screwing them together, what if the radial head is just too smashed up to fix?
Good question. In really severe cases where the fracture is highly fragmented and we call comminuted, and it's just not possible to piece it back together reliably,
Then what?
then radial head replacement might be the answer. The surgeon removes the damaged radial head fragments and replaces them with a prosthetic implant.
Wow, an artificial radial head.
Yep. The choice between ORIF and replacement depends heavily on the fracture pattern, the quality of the bone, the patient's age, and activity level.
So, for revision, the big dividing line is basically displacement and complexity. Simple break, likely conservative. Messy break, likely surgery either fixing it or if we're replacing it.
That's a really good way to think about it.
Right.
And the notes do stress that treatment has to be individualized. What's right for one person might not be right for another, even with a similar-looking fracture on X-ray.
Right. Okay, looking down the line, prognosis. Once someone's had the fracture and the treatment, what's the likely outcome? Do people generally get back to normal?
The notes, particularly focusing on the UK context, suggest the prognosis is generally favorable. Most people do heal well and regain good elbow function.
That's good news. Are there factors that can make the prognosis, well, less good?
Yes. The notes mention that associated injuries play a role. If there were significant ligament tears at the same time, for example, that can lead to ongoing instability, which impacts the outcome.
Okay. And what helps ensure a good outcome?
The key factors highlighted are getting an early diagnosis, making sure the treatment choice is appropriate for that specific fracture, and this is crucial, dedicated rehabilitation afterwards. Physio is really important.
Rehab keeps coming up. Seems vital.
Absolutely. It links management to long-term function and preventing complications.
Okay, let's talk about those. Complications. While most heal well, what can go wrong? What are the potential bumps in the road?
Yeah, even with the best management, complications can unfortunately occur. The notes list several important ones to be aware of.
Like what?
Mnemonic is one, that's where the fracture heals,
Mm.
but the bone pieces are in the wrong position, they're misaligned.
Which would affect movement, presumably.
Definitely.
Yeah.
Then there's non-union, where the fracture just fails to heal together at all.
Okay, that sounds problematic too. What else?
Elbow stiffness is a big one. Even after the bone heals, the joint might remain stiff with limited range of motion. Chronic pain can also be an issue for some people.
Mm-hmm.
Instability, too, the elbow feeling loose or wobbly, especially if ligaments were damaged. And then longer term,
Yes.
post-traumatic arthritis. Arthritis developing in the joint later on because of the damage from the initial injury, or maybe issues like Mnemonic.
Right, the joint surface damage leading to wear and tear down the line. And how do you try and avoid these?
Well, as the notes emphasize, timely and appropriate management, getting the right treatment early, and really sticking with the rehabilitation program are key to minimizing the risk of these complications.
So again, it comes back to good initial treatment and good physio.
Exactly. And notice how many of those complications, stiffness, instability, arthritis, aren't just about the bone itself, but about the whole joint's function and health. It's a good reminder when revising.
Definitely. Okay, so we've really covered a lot there from the notes you shared. What a radial head fracture is, how it happens, who gets it, how it presents, how you diagnose and treat it, and what the outcomes and potential problems are.
Yeah, hopefully breaking it down like this, section by section, and pointing out those links like how displacement affects treatment or how rehab helps prevent complications, makes it all a bit clearer and stickier for revision.
Absolutely. Thinking about those complications, especially stiffness and the risk of arthritis, it really hammers home that treating this isn't just about getting the bone to heal, is it?
Not at all. It's fundamentally about preserving the function and the long-term health of the whole elbow joint.
That's a really important final thought, something to definitely chew on as you review these notes.
Indeed.
Well, thank you for joining us for this deep dive. We hope it's been helpful and high yield for your MSRA prep.
And just a reminder, for more revision resources, do check out pastamsra.com and freemsra.com.
We'll catch you on the next deep dive.